Welcome to KEMCA UK YouTube channel. As you know, we are uploading the videos for educational purpose and for public awareness. Today, one of the leading experts from Leicester, UK is joining us to give us an overview of the recovery trial and the treatments available so far. If you like this video, please share it on social media, subscribe the channel and then press the bell icon next to it.
Thank you, KEMCA UK. So today we are going to appraise the available evidence for the treatment of COVID-19 infection so far. We have got an expert and prolific researcher, Dr. Neil Greening, with us today, who is heavily involved in conducting recovery trial, which is the biggest trial in the world on finding new treatments for management of COVID-19 infection. He is a consultant colleague and associate professor at Leicester NIHS. So, thank you very much for your time, Neil. My first question is, how did you start recovery trial? I know it is still going on. What are your findings so far? And we hear the news from yesterday that you have found the first medicine which reduces the mortality associated with COVID-19 infection.
Thank you, Mohammed. And thank you for inviting me here. It's been really exciting. As you know, Leicester is a large centre for research. And when COVID-19 came out, or came upon us, we realised that we knew nothing really about it, and certainly no obvious treatments. One of the most important things that when you're doing medicine is to give proper treatment that is evidence-based. So the UK took quite a different approach. It's a very unique setup because we have the National Health Service and the NHS, which is a joined up service, so we're able to coordinate across many sites. And the decision was taken that we should do particularly one large trial which might have several arms of different therapies. So the recovery trial was set up. It was led by Oxford, but I'm pleased to report that Leicester was by far the largest recruiting centre in the country. And the UK recovery trial has now recruited over 12 or nearly 12,000 patients to the one trial alone. The idea behind it was that you would have a usual care or standard of care group. Because we don't know or didn't know if any of these medicines were effective, we felt comfortable in just giving a standard of care treatment, nothing extra. And added on to that, we've trialled various therapies which have stopped and started at different time points depending on where the evidence was. Most excitingly, more recently, the results of the Dexamethasone arm have come out, but we've also tested hydroxychloroquine. We're currently testing convalescent plasma, testing tocilizumab, as well as some other antiviral therapies. The most exciting result, which I think is of most interest worldwide, is that of dexamethasone. So the recovery trial recruited 2,000 patients to dexamethasone arm of the trial. What's really exciting about that is a group where there's very little exclusion criteria. So really anyone coming into hospital with COVID-19 was eligible to get dexamethasone, which isn't the case for all therapies. This was then compared to over 4,000 patients who received standard of care group. And what's been really exciting is that we have the headline figures is that we've seen a reduction in the mortality in patients who've received dexamethasone. This is low dose steroids, so slightly different to some of the earlier methylprednisolone studies we've seen in ARDS. So this is low dose dexamethasone, 6 milligrams, which is equivalent to 40 milligrams of prednisolone, roughly. This has shown a reduction in mortality in the most severe population, a moderate reduction in those with moderate disease, and no difference in those with mild disease. So what's really interesting is there seems to be not a dose effect, but an effect on the severity. So a 30% reduction was seen in those that were intubated and ventilated in terms of mortality, and a 20% reduction in those that were requiring oxygen. That means that if you were to treat 8 patients who'd been intubated, 1 would survive who would have otherwise died. In terms of oxygen, if you treat about 25 people, about 1 of them will have survived who would have died otherwise. And those results are absolutely astounding. And I have to say, it surprised us a little bit, and it just shows the importance of doing proper randomized control trials, because dexamethasone was not a drug that was being tested in other countries. It was considered potentially not of benefit because of the earlier ARDS high-dose steroids trials, but it has been shown to be very effective and actually a very cheap, readily accessible drug, which is great.
As you know, dexamethasone is a cheap medicine and easily available throughout the world. Do you see any abuse of this medicine in those countries, even for mild disease? And obviously, this is not a benign medicine. It does come with some side effects. And also, what are your views about hydroxychloroquine? Should people still be using hydroxychloroquine?
For dexamethasone, the worry is that it is readily available and is very cheap. Now, on the one hand, that is possibly some of the best news I can think of. We aren't talking about an expensive drug, we're talking about a drug that could genuinely be available to anybody in the world, and one that doesn't require difficulty in getting hold of. But you're right, what we don't want to do is give it to everyone when there may not be benefit. I actually really look forward to seeing the full results from the recovery trial of this arm, because all we know at the moment is the headline figures around mortality, and the only benefit we've seen in mortality are those requiring oxygen or those that are intubated and ventilated. Quite categorically, there is no mortality benefit in those not requiring oxygen with milder disease. What will be interesting is when we see the secondary outcomes, perhaps on recovery rates or length of time in hospital, to see if there's any difference in mild disease, and I don't know. For hydroxychloroquine, it's slightly different, because I think we can be fairly sure now that that does not work. There was a large trial that was reported that has now actually been retracted, suggesting that hydroxychloroquine may not be safe. There's been difficulty in getting hold of the data, so actually the authors have retracted that, so we're not counting it. But the recovery trial has actually published the headline figures for hydroxychloroquine a couple of weeks ago. Because it wasn't positive, it didn't get the same headlines, but I think it's equally important, and that categorically showed that any way of giving hydroxychloroquine was not associated with mortality benefit. It didn't cause a mortality harm signal that has otherwise been reported widely elsewhere, but certainly offered no benefit. So I think we can safely exclude hydroxychloroquine as a treatment for COVID pneumonia, and there had been possible trials of prevention and prophylaxis, but again, we haven't seen any positive trials, and indeed there have been some negative trials for that. So I think we're going to stop at hydroxychloroquine. Dexamethasone definitely in those requiring oxygen, definitely those requiring intubation. At the moment, not in those with milder disease, but let's wait and see what the full results show.
There has been an increasing interest in another medicine, Remdesivir, which has been previously tried for Ebola virus, and there has been some trials coming out of it. How do you appraise the evidence for this?
So Remdesivir is an interesting drug, and before the dexamethasone story was the one that everyone was talking about and had actually been rushed through and approved by people like the FDA. So there have been a few studies in Remdesivir, a number of including randomized controlled trials, one from China which was negative but stopped early because of lack of patients, but another multinational one which was more positive. And there has been some improvement seen with Remdesivir. We haven't seen the same mortality benefit that we've seen with dexamethasone. What we have seen, however, is a reduction in the length of time that it takes to recover. So in the large randomized control trial, the average length of treatment required before improvement, half of the people got better, was 15 days with usual care, but only 11 days with Remdesivir. So it offered a little bit of improvement in the number of days with symptoms, but nothing like what we've seen, and nothing quite to the same extent as dexamethasone. So yes, some positive stuff about Remdesivir, and yes, we are using it a little bit, but perhaps not the hope that we had with it when it first was being tested.
We know tocilizumab is one of the arms in the recovery trial, and we eagerly await for the results. But there are some cohort and observational studies for its effectiveness. how will you appraise use of tocilizumab?
Actually, the results of dexamethasone make me more excited about tocilizumab, because dexamethasone, by its mechanism of action, is suppressing the immune system and reducing the inflammation, which is exactly what tocilizumab, an anti-IL-6 drug, is also designed to do. So actually, the results of dexamethasone make me more positive potentially about tocilizumab. But you're right, there have been no randomized controlled trials yet of tocilizumab. The recovery trial will be vital to that. There have been a number of cohort studies where they have looked at patients, they have given tocilizumab, because across the world it is being given on a compassionate basis, and because we're not sure what to do, some centres have been giving that, and they've compared it with people who have not been given it. Obviously this isn't in a randomised manner, so it's not always perfectly matched. And the early retrospective data and the cohort data seem to be fairly positive. There has been reported improvements in mortality. The trouble is not matched against anyone else, but compared with other people not given it. So that would make me think that there's certainly something potential for tocilizumab. I really eagerly await the results.
Convalescent plasma has been in use for different diseases for many decades, and there has been an increasing interest in the use of this, I will say, easily available and very benign treatment for COVID-19 infection. And we see there is some randomized controlled trial evidence coming from China, I think. So what will be your views about the use of convalescent plasma?
Yeah, as you say, very attractive in the way that it is like dexamethasone, cheap and readily available, and that I always think is a great start to medication. Also, safety is something we need to think about. We give treatments that aren't always benign and may be associated with harm. So when we don't know, giving treatment that is safe, even if it has a smaller benefit, may be helpful. But convalescent plasma, there has been one randomized controlled trial in China. Again, sadly, it had to be stopped a little bit early because they ran out of patients, because they'd managed to control the spread of the pandemic locally, so they weren't seeing any more patients. So the results are tempered a little bit. And so the overall results of the convalescent plasma trial were negative, but there were some signals in there that really suggested that there might be something in it. So there was reduction, although not significant, in things like mortality, but it was stopped short of being able to show anything. So convalescent plasma is another one that I'm definitely keeping my eye on, really looking forward to the arm of the recovery trial and other convalescent plasma trials that are going to come out. And I look forward to it because it's one that I can see being given globally, and one that I know has a good safety profile.
Ivermectin is an anti-parasite medicines, and especially in one American study, they have shown some benefit about ivermectin. I will be keen to know about the use of ivermectin.
So ivermectin's one that it's actually been around for a long time. It's been around since I think the 1970s, and has been tested in a number of parasite infections, things like Zika, with mixed effects depending on the condition. And there has been some evidence suggesting that it might be certainly worthy of further investigation and proper trials. There has been as you say, in America, I think it was Florida, I have to double check, a trial, not randomized control, but comparing people who'd had it alongside people who'd not had it. They attempted to match the patients. It was a bit tricky because those that didn't get it, a few more had things like COPD and long-term lung conditions. But again, those that received the anti-parasite drug seem to do better. So this is certainly a drug I'm really, again, looking forward to seeing the results of. It's interestingly one that we're not testing in the recovery trial, so I'm hoping somewhere else in the world has picked it up and doing a good job at finding a good evidence base for it to see if it works.
Take an example of a patient. Let's say a 54-year-old gentleman with no comorbidities is admitted under our care and is confirmed COVID-19 infection on swab test, and patient is requiring 6 liters of oxygen to maintain oxygen saturation more than 92%. What will be your approach in the management of this patient, keeping in mind all the evidence we have discussed?
It's very good to talk about the research, and it's so nice to see it's important, but actually at the end of the day we're clinicians and we want to treat the patient in front of us. The way I always think about it is I always want to give the best treatment I can do, but at the same time I don't want to cause harm to my patients, and that's something that's really important. I worry that we sometimes as medics, we want to do as much as we can do, and by that we give as much therapy as possible. Now, we know from other conditions that that's not always the right way forward. Actually, what we give is not always benign and may cause harm. So my first thought is, what's the safety profile of something? Is it going to cause benefit? What's the likelihood of it causing benefit? But what's the likelihood of it causing harm? And I think we have to balance that up, and that's why evidence-based medicine is so important. So in the case of a 54-year-old gentleman needing oxygen, he's at very high risk of deteriorating. I would do the basic things well, so I would absolutely be controlling their oxygen. I would be wanting to monitor him really closely and have early interventions for things like further respiratory support, probably intubation and ventilation. We might think about things like CPAP, but we don't know the safety profile necessarily of things like that. And then we would see, based on the results of the Dexamethasone arm of the recovery trial, I would have no hesitation in giving Dexamethasone to this patient. Would I give Remdesivir? I probably would do, actually. We do know that there is a small effect in it. We have had positive trials and it does seem to be safe. So I would certainly very carefully consider Remdesivir and probably give it. Would I give the other drugs? I probably wouldn't outside of clinical trials yet, because I don't think the evidence is there. Things like tocilizumab, I really hope are effective, and I really hope that I can give it in the future. But undoubtedly, even with the cohort studies, we have seen harm associated with it, doubles the risk of ventilator-associated pneumonia. So it's not about a matter of giving it in case it works, it's a matter of giving it but considering the consequences as well. And the same with convalescent plasma as well, although that might have be a safer drug we need to see. So I would give do the basics well. I'd give proven therapies, so Dexamethasone, certainly, probably Remdesivir, and then I would think about research or trials for them. If push came to shove, I would think about what's the chance of this person doing badly, what might benefit them, but what might I do to make things worse?
Next question is about UK approach about treating these patients with COVID-19 infection. We know in many countries people have been using all these medicines right from the beginning outside clinical trials, though we have been very strict in getting the patients into clinical trials. Hence we got the results of Dexamethasone and hydroxychloroquine. You have partially answered this question already. So what are your views on the approach of other countries using all these medicines on patients outside clinical trials? And usually if there is an unwell patient in front of you who is dying potentially, and usually a knee-jerk reaction of the clinician is to give each and every medicines to make them better.
I think the word knee-jerk is a great description of that, because that's exactly what we think about. What we have to do is step back, think objectively, think with passion and compassion, but think about who are we treating and why are we treating it. Sometimes, unfortunately, as a medical profession, we tend to treat ourselves or try to make ourselves feel better because we feel we have to do something. We have to give every drug going on the off chance it might work. And we have to be careful with that approach because we don't know that all these therapies work, and it may well be that some cause harm. And we certainly have seen that with other diseases. Within respiratory medicine, interstitial lung disease is a great example where we gave drugs that poisoned people for many years on belief that it worked. So I think the UK approach has actually been exactly right, which is if we don't know, don't rush in, try and have a good setup for a clinical trial, because then you can definitely answer it. And once you've definitely answered it, then you can either give that to anyone in the world, or you can say, well, hang on, it's not working. It's either going to cost money or cause harm, we don't need to give it. So I would always think about the patient. Don't necessarily rush in. Think about, is it the patient I'm treating or is it my anxiety?
Thank you. That is a very good point. And also, if you give medicines outside clinical trials, you miss the opportunity of testing these medicines by taking them into research. So viewers, we have heard from the expert from the United Kingdom about the proven and available medicines for treatment of COVID-19 infection and what the future holds. And hopefully we will have more results in coming weeks, especially from the recovery trial, and we eagerly await for the results. And I hope that you will find it useful to get the views of our expert from United Kingdom. Thank you.